If a patient is promised that an injection of, well, her own blood will cure her sexual dysfunction, how does a doctor actually prove that it worked?
Right, because you can't exactly put human pleasure on a scale.
Exactly. I mean, you can't just draw blood to measure an orgasm.
Mm.
So today, we're looking at the exact math that science uses to measure the unmeasurable. Welcome to the deep dive.
Glad to be here for this one.
Today, we are exploring this really fascinating collision of two completely different worlds. On one side, you have the bold claims of regenerative medicine, specifically the O-shot.
Which are huge claims.
Right. And then on the other side, we have this incredibly complex science of trying to mathematically quantify highly subjective improvements in a woman's sex life.
It is honestly the absolute definition of diagnostic muddy waters.
Yeah.
When you're dealing with these deeply personal human experiences,
Yeah.
translating that intimacy into clinical data that a doctor can actually use, it requires a very specific kind of architecture.
Because we're trying to evaluate subjective improvements, right? Like natural lubrication and climax, and somehow turn those into objective, hard data points.
Yeah, exactly.
And to do that, we're pulling from a pretty massive stack of sources for you today. We're looking at literature from aesthetic clinics, urogynecology centers,
It's like the Clark Center, right?
the Clark Center, and Optimal Medical Group. Plus, we're parsing through clinical trial data.
Including that initial 2014 renal study.
Right, and some highly rigorous randomized controlled trials, too. And finally, we're digging into the scoring rubrics from psychology labs, like the UT Psychology Lab, to just really unpack the mechanics of a tool called the Female Sexual Function Index.
Or the FSFI.
The FSFI, yeah.
And the FSFI is really the bridge here. I mean, it's how the medical community attempts to validate or, sometimes challenge the physical promises made by treatments like the O-shot.
Okay, well, let's unpack those promises first. What exactly is the O-shot? Looking at the clinical literature, it's a non-surgical procedure that uses platelet-rich plasma, or PRP.
Right, and the underlying premise of PRP, I mean, it's been utilized in orthopedics and wound healing for years.
Oh, really?
Yeah, it's not new in that sense.
Sure.
The process starts with a standard blood draw from the patient's arm.
Yeah.
That blood goes into a centrifuge.
Which is just rapid spinning, right?
Exactly, rapid spinning to separate the red blood cells from the plasma and the platelets. So you're left with this highly concentrated serum of the patient's own platelets.
And these platelets, from what the sources say, they are essentially just packed with growth factors.
They are. Growth factors are proteins that act as, like, cellular messengers. They signal the body's local cells to repair, regenerate, multiply.
Okay, so in the context of the O-shot, after they apply a topical numbing cream, this concentrated PRP is injected directly into the clitoris and the anterior vaginal wall.
Right.
And the theory here, according to these urogynecology sources, is that introducing these growth factors to such sensitive areas, it stimulates a whole cascade of regeneration.
A biological cascade, yeah.
We're talking about the production of new collagen, new blood vessels, new nerve tissue, and that cascade leads directly to the specific outcomes we're focusing on today, which are increased natural moisture and stronger, more frequent orgasms.
Right, and the biological mechanism they're targeting there is called angiogenesis.
Which is the formation of new blood vessels.
Exactly. So by encouraging angiogenesis, you theoretically increase localized blood flow. And increased blood flow is the fundamental physical driver of arousal and natural lubrication.
Wow, okay.
Simultaneously, by stimulating nerve tissue regeneration, the goal is to enhance physical sensitivity, which obviously directly impacts a woman's ability to reach climax.
Okay, to visualize what they're attempting here, I was thinking about a dry, struggling lawn.
Okay, I like where this is going.
If you just spray paint the dry grass green, sure, it looks better for a weekend, right? But the root problem hasn't changed. That is essentially what temporary artificial lubricants or even some short-term topical hormone creams are doing. They just mask the symptom.
Right, they're the green paint.
Exactly. But the O-shot claims to be more like aerating the soil and adding this customized fertilizer. You're prompting the root system to grow its own natural, healthy grass again. You are literally restoring the cellular environment.
And that distinction, between masking a symptom and actually regenerating tissue, that's the entire foundation of aesthetic and regenerative medicine. The goal is autologous repair.
Autologous repair.
Yeah, using the body to heal the body.
Okay, so we have this beautiful theory of regenerated tissue. The lawn is aerated and fertilized. But how do you prove the grass is actually greener when you're dealing with human sexual satisfaction?
That is the big question.
I mean, to get this treatment taken seriously in the medical community, researchers had to figure out how to mathematically measure an orgasm. How do you even begin to do that?
Well, you need a standardized, validated tool. You absolutely cannot run a clinical trial where the only metric is a patient shrugging and saying, hey, I feel better. Well, that's the ultimate goal for the patient. Obviously, it just doesn't hold up to scientific scrutiny. You need a way to quantify this objective.
Enter the Female Sexual Function Index, the FSFI.
Yes.
Looking at the rubrics we got from the UT Psychology Lab, this is a 19-item questionnaire. Women basically reflect on their sexual function over the previous 4 weeks.
And it uses a standard 5-point Likert scale, right?
Yeah, typically ranking from 1 to 5, with some questions offering a 0 if, there was no sexual activity during that window.
Right. And what's fascinating here is how those 19 questions are categorized. They're broken into 6 distinct domains of sexual function.
Which are?
Desire, arousal, lubrication, orgasm, satisfaction, and pain.
Okay.
By segmenting the experience like that, a clinician can isolate the exact mechanical or psychological breakdown in a patient's sexual response cycle.
Since our focus for you listening is on how clinicians evaluate improvements specifically after the O shot, let's just look at the 2 domains the procedure actively targets: lubrication and orgasm.
Good idea.
How does a piece of paper actually capture the reality of wetness and climax?
Well, if we look at the lubrication domain, it relies on questions 7, 8, 9, and 10. And these don't just ask a binary, were you lubricated?
Right. A simple yes or no wouldn't be enough.
Exactly. They evaluate frequency and difficulty. So how often did you become lubricated during sexual activity? How difficult was it to achieve?
Okay.
And most importantly, how difficult was it to maintain that lubrication until the completion of sexual activity?
Because it's capturing the entire physical arc. I mean, initiating moisture is one thing, but maintaining it throughout the encounter is, it's a completely different physiological challenge.
It really is.
Yeah.
Then you move to the orgasm domain, which is captured in questions 11, 12, and 13.
Right.
It assesses the frequency and the difficulty of reaching climax. But the brilliance of this specific domain is the third question, because it explicitly asks about the satisfaction with the orgasm.
Which means it's not just a mechanical checklist.
Yeah.
You could have a physiological release that feels completely emotionally or physically underwhelming. So the FSFI is trying to capture the quality of the experience, not just the existence of it.
Right. It recognizes that a climax without satisfaction is still a form of dysfunction for that patient.
Okay, as I was digging through the scoring algorithms in the source stack, I found this mathematical quirk that really threw me.
Oh, the multipliers.
Yes. The sources show that to calculate your final score, your raw score for the lubrication domain is multiplied by a factor of 0.3. But your raw score for the orgasm domain is multiplied by 3.4. Wait, why have the different math?
It's confusing at first glance.
Yeah, why are they curving the grades differently for these 2 experiences?
Well, it looks like a discrepancy, but it's actually an incredibly elegant solution to a structural problem in the survey itself.
Okay, how so?
The multipliers don't mean an orgasm is inherently more valuable than lubrication. They just exist to equalize the domains on the final scorecard because they have a different number of questions.
Because lubrication has 4 questions, but orgasm only has 3.
Precisely. Think about the math. If a woman answers a perfect 5 on all 4 lubrication questions, her maximum raw score is 20.
Right.
But if she answers a perfect 5 on the 3 orgasm questions, her maximum raw score is only 15. If you didn't adjust for that, lubrication would unfairly dominate the total score, just by sheer volume of questions.
So they use the multiplier to level the playing field.
Exactly.
A raw score of 20 for lubrication multiplied by 0.3 gives you a maximum domain score of 6.0.
Yep.
And a raw score of 15 for orgasm multiplied by 0.4 also gives you a maximum domain score of 6.0.
You got it. Every single one of the 6 domains, desire, arousal, lubrication, orgasm, satisfaction, and pain, they're all placed on a perfectly comparable scale with a maximum score of 6.0.
That is so smart.
By mathematically equalizing these domains, the medical community is making a pretty bold statement.
Which is?
That a woman's ability to lubricate naturally is given the exact same clinical weight and importance as her ability to achieve a satisfying orgasm.
That is a profound way to look at the diagnostic architecture. It validates both experiences equally.
It really does.
Okay, so they built this perfectly balanced mathematical scale, but what happens when you actually put the O shot on it?
Right, the real test.
Yeah, when you give this test to women who just had their own plasma injected into their bodies, do the numbers actually back up the hype from the cosmetic clinics?
Well, this is where the medical literature splinters a bit. If you look at the early pilot studies and the observational data, the results look incredibly promising.
I was looking at the notes on this 2014 pilot study by Dr. Charles Runels. He's the physician who actually trademarked the OSHA, right?
Yes, he is.
So his study claimed a 64% improvement among participants. And the study noted statistically significant increases specifically in the FSFI subscales for both lubrication and orgasm after the injections.
Right.
But it was a tiny pilot study. I mean, only 11 patients. Does data from a study that's small actually hold up when it's expanded?
It does find support in slightly larger independent trials. For example, the sources include a 2019 study published in the Turkish Journal of Obstetrics and Gynecology.
Okay, what did they find?
They followed 52 women diagnosed with sexual dysfunction. After administering PRP injections to the anterior vaginal wall, researchers recorded statistically significant improvements in their overall FSFI scores,
Wow.
and they explicitly highlighted the positive movement in the orgasm subdomain.
Plus, you have the sheer volume of patient-reported anecdotal data. On the cosmetic review site RealSelf, the O-Shot maintains an 86% worth it rating.
Which is remarkably high.
Yeah, while that's highly subjective, an 86% rating in the cosmetic procedure world means a vast majority of women are logging on to report dramatic, real-world improvements in their natural moisture and their ability to finally climax.
The high patient satisfaction is undeniable. But when you introduce placebo controls into the research, a much more complicated narrative emerges.
Oh, interesting.
Because the pilot studies show what happens when women know they are getting the treatment. The randomized controlled trials show what happens when they don't.
And this brings us to the conflicting data from BINAS. They detail a rigorous, randomized, placebo-controlled trial.
Right.
They took a group of women receiving actual vaginal PRP injections and compared them against a control group receiving sham injections over a 6-month period.
And in medical research, the placebo-controlled trial is the gold standard.
Because it isolates the chemical or biological effect from the psychological expectation of healing.
Exactly.
Yeah.
And the data table from this specific trial is quite stark.
An adjusted p-value of 1.00. That's what the data showed for desire, arousal, lubrication, and orgasm when comparing the PRP group to the control group at the 6-month mark.
Which means there was absolutely zero statistical difference between the two groups.
The women who received the actual PRP shot and the women who received a saline injection reported the exact same outcomes on their FSFI questionnaires regarding their lubrication and orgasms at 6 months.
That's wild.
But if the placebo group showed the exact same improvements, does that mean the cellular regeneration, like the angiogenesis and the nerve growth, isn't actually happening?
Well, if we connect this to the bigger picture, it means that in that specific large-scale trial, they could not prove a statistically significant physical difference from the placebo effect using the FSFI metric.
Right.
But it also highlights a known, incredibly powerful phenomenon in sexual medicine. The brain is arguably the most vital sex organ.
Oh, absolutely.
The psychological impact of simply seeking treatment, of paying for a procedure, of having a clinician validate your intimate concerns, and really believing you're receiving a powerful intervention, that anticipation alone can cause a profound, highly real improvement in physical sexual function.
So the act of taking agency changes the physiological response.
Yes.
So what does this all mean for you, the listener? If you are looking at this wildly split data between miraculous pilot studies and totally flat placebo trials, what does this mean for the actual efficacy of the shot?
It's confusing for patients.
It is. The sources are transparent about this variance, though. While 60 to 85% of women report improvement in clinical settings, 15 to 40% may not see any significant changes at all. It is just highly individualized.
And because the response is so individualized and the data is so mixed, it completely changes how a clinician sitting in an exam room interprets a patient's FSFI score.
How so?
They aren't looking at this questionnaire to hand out a universal passing or failing grade for the O-shot. They are using it to track a personal evolution.
Okay, let's talk about how doctors actually use this math in practice. We established that the full FSFI scale, when you add up all 6 domains, ranges from 2 to 36.
Correct.
And according to the clinical guidelines, a total score below 26.55 is the established cutoff for diagnosing female sexual dysfunction.
Right, so if a patient's total score across all domains is below that 26.55 threshold, it flags a clinical level of dysfunction that warrants medical attention.
But the UT Psychology Lab sources reveal a crucial limitation of the tool. That cutoff only applies to the total score. Individual domains, like orgasm or lubrication, do not have an established diagnostic cutoff.
And this is vital for understanding how the tool is used. A doctor cannot look at a woman's isolated score of, say, 2.5 on the orgasm domain and use that number alone to definitively diagnose her with a condition like female orgasmic disorder.
Really?
No, the tool simply wasn't designed to diagnose specific disorders based on isolated subscores.
Here's where it gets really interesting. It's almost like tracking your personal best time in a 5K race rather than worrying if your time qualifies you for the Olympics.
That's a great way to put it.
The clinician is only comparing you to you. It's like a pain scale. A doctor doesn't use your 7 out of 10 pain rating to diagnose whether you have a broken bone or a torn ligament.
Right.
They use it to establish a baseline. Then they provide treatment, and they check to see if that pain rating drops to a 3-foot. The score is a compass for your personal journey, not the diagnostic threshold itself.
That is a much better way to conceptualize it, because they cannot use the lubricating or orgasm domains for a definitive diagnosis. Clinicians use those specific scores purely for tracking treatment progress.
Okay,
They're comparing the patient only to herself.
so how does that actually play out in the clinic timeline? A woman comes in seeking the O shot for vaginal dryness. What happens next?
Well, before any procedure is done, the doctor will have the patient complete the FSFI questionnaire. This establishes her baseline, her personal zero, essentially.
Makes sense.
Then they administer the O shot, because the biological regeneration of tissue takes time. I mean, angiogenesis doesn't happen overnight. The doctor will have the patient take the FSFI again, typically 4 to 6 weeks later.
Okay.
And they will likely test again at the 3-month mark, when the peak effects of tissue regeneration are usually observed.
So they aren't looking to see if her orgasm score hits some magical standardized number. They are looking to see if that 0.4 weighted score moved from, a 2.0 to a 4.0.
Exactly.
Yeah.
The absolute number matters far less than the delta, that change between her baseline and her post-treatment score.
Right, the difference.
If her score goes up, and she reports less difficulty and higher satisfaction with her orgasms or her natural lubrication, the treatment is a clinical success for her.
That's fascinating.
The subjective experience of the patient, translated through this mathematical index, is the ultimate metric.
It's an incredible blend of hard science and deeply human experience. To wrap up today's deep dive, we've covered a massive amount of ground for you today.
We really did.
We explored the regenerative promises of the O shot, which claims to use your body's own localized growth factors to stimulate new blood vessels and nerve tissue.
You're right.
We broke down the precise equalizing math of the FSFI, discovering why a 0.3 and a 0.4 multiplier are necessary to give lubrication and orgasm the exact same clinical weight.
A very clever piece of math.
And we navigated the highly nuanced clinical data where enthusiastic pilot studies clash with the undeniable power of the placebo effect.
It is just a reminder that evaluating female sexual wellness is never a one-size-fits-all endeavor. The metrics we use have to respect the immense complexity of both the human body and the human mind.
Which actually brings me to a final thought for you to ponder, drawing on one last piece of our source material. There is another tool mentioned in the literature called the FSDS-DAO, or the Female Sexual Distress Scale.
Ah, yes.
While the FSFI measures mechanical function, how often you lubricate, how easily you climax, the distress scale measures the frustration, the guilt, and the bother a woman feels about her sexual function.
It measures the psychological weight of the dysfunction rather than the mechanics of it.
Exactly. So consider this. We know the O-shot's physical success is highly variable. We know that up to 40% of women might not see a massive physical change on the FSFI scale.
Right.
And we know the placebo effect in these trials is incredibly strong. But what if the simple act of seeking treatment, of taking agency, and having a doctor validate your concerns dramatically lowers your psychological distress on that FSDS-DAO scale?
That's the real question.
If a woman's mechanical function barely changes, but her anxiety and frustration about it disappear entirely, is that psychological relief actually the true measure of a successful treatment?
It really forces us to ask, how we define healing in sexual medicine. I mean, is healing always a structural cellular repair?
Or is it something else?
Or is it sometimes a fundamental shift in how we experience and accept our own bodies?
The landscape will always be complex. You can't just put human pleasure under a microscope. But tools like the FSFI and the distress scale, they give us a mathematical flashlight to start navigating that terrain. Something for you to think about. Thanks for joining us on this deep dive. We'll catch you next time.